Okay, welcome everybody. We will begin in just a few minutes. We're waiting for everybody to join today's virtual seminar. All right, already see some nice comments in the chat, and we'll start in about, how about 30 seconds, just waiting for everybody to log in, get ready, get their notes set up, and we will begin. Okay, let's go ahead and get started. So welcome everybody. We are so glad you are here with us today. My name is Liz Wellinghorst, and I am the Director of Regional Integrated Marketing for the American Cancer Society. And it is my pleasure to welcome you to the event today. We ask that if you have multiple people listening from one line, that you please enter your name and organization in the chat so we have a record of your attendance. All lines will be muted during the program, and we ask that all questions be entered into the Q&A tab on your screen. We will be taking questions. We will be taking questions during our panel discussion and at the end as time permits. If we do not have time to answer your question during the panel, we will work with the presenters to have your questions answered post-event. Okay, let's go ahead and begin. This is our first poll question. What sector do you represent today? Again, what sector do you represent? We will have several polls throughout today's program, and we do appreciate your participation. Okay, I see them coming in, and really from all over the country. We have Idaho, it looks like Connecticut. Okay, just waiting for those poll answers to come in. Okay, wonderful, thank you for that. So before we begin our program, we wanted to recognize and thank our sponsors. Without the generous support of the Ohio State University Comprehensive Cancer Center, here's our poll answers. Okay, mostly from hospital systems. And then we have community organizations, great. Okay, wonderful. Again, we wanted to recognize and thank our sponsors. Without the generous support of the Ohio State University Comprehensive Cancer Center, the James Cancer Hospital, and United Healthcare, this program would not be possible. Also, thank you to the Ohio Partners for Cancer Control and Mountains of Hope Comprehensive Cancer Coalitions for their continued support. And here is our agenda for today. All right, we will begin. We will have a survivor and ACS CAN volunteer speaker, then followed by 4 presentations. After those presentations, the speakers will join our panel discussion. And then we will conclude with some information on American Cancer Society, resources, and housekeeping items. The AAFP has reviewed Navigating Social Determinants of Health in Cancer webinar and deemed it acceptable for up to 2 enduring materials, self-study AAFP prescribed credits. You will receive a certificate to claim your CEs within 2 weeks following completion of the post-event survey. Our objectives for today's event can be seen on the current slide. Please note that the planning committee members and speakers have declared that there are no relative financial arrangements or affiliations with the organization that may affect balance, independency, objectivity, or scientific rigor for the CE event. Also, please note that slides will be available after the presentation, and this event is being recorded. Okay, now time for our second poll question. Please take a moment to indicate how you are currently feeling about your knowledge of issues in cancer survivorship. Again, how are you currently feeling about your knowledge of issues in cancer survivorship? Not confident at all, slightly confident, and confident somewhat. Wonderful, thank you for that. So next up, please join me in welcoming Julie Turner. Julie Turner is a 49-year survivor of stage 3 Hodgkin's disease. As a volunteer, Julie has been active with the Relay for Life movement for the past 28 years. Relay opened the door to advocacy, where she joined the American Cancer Society Cancer Action Network. Sorry, I'm not finding my slides here, sorry. Which is also known as the ACS-CAN, and is now the lead advocate for the 15th Congressional District in Ohio, and is active in the ACS-CAN Emeritus. Welcome, Julie.
You have me there? There
Yeah,
we
hi,
go.
Julie.
There we go. Hi, everyone. I am thrilled to be here today. As you know, I am a 49-year stage 3 cancer survivor, and my journey began so long ago that most people would think I wouldn't remember everything that happened to me during that time period. However, I can recall almost every day. As I think back over the past 50 years, two words come to my mind. Intense fear and intense gratitude. I was told I had cancer, and I was whisked off to Ohio State before the James. And I had in tow my mom and dad and my sisters. I received great care at Ohio State. But understanding my roller coaster of fear of treatments was nonstop. My mother never wavered in her care, and in my mind, single-handedly willed me back to health. She held me so tightly in the palms of her hand that I was going to follow every direction, every suggestion, no stones unturned with my mom. So during the fall of my senior year in high school, I was diagnosed with cancer and whisked to OSU Medical Center before the James. Testing would tell my family that I had stage 3 Hodgkin's disease, and that all of my infected nodes were from my neck to my groin on my left side. My family and I knew that this really wasn't good news, but we were in the fight for our lives. I have vivid memories of those days. Extreme fatigue that overwhelmed my mind and my body. The parade of medical students and interns and residents and doctors who asked sometimes the same questions over and over and over again. It was sort of a game with my mom and I. If I had already answered the question, I'd look over and wink at her. The fear that I felt every day was crippling. But the loving care of my stay-at-home mom that sat at my bedside every day, knitting and crocheting, teaching me to cross stitch, and we would paint and color to pass the time. As an outgoing patient, as an outpatient going back to the hospital, during that hour-plus ride, I would already be sick before I made it to the hospital. I remember medical smells and tastes that to this day haunt me. They can nauseate me in a heartbeat. The burning of my skin with radiation, my throat burned, the unending nausea and vomiting from MOP chemotherapy that for some lasted maybe 24 to 36 hours. Unfortunately for me, it lasted days, ending just in time to prep for another treatment. As an outpatient, I remember one day laying on the bathroom floor, too weak to get back to the bed before I knew I would come back to the bathroom again. And I prayed to God cancer was going to take me. Let's do it now. I'm ready. I remember my mom coming into my hospital room every day, and she would say, be strong, be brave, Julie, do it for me. And some days she'd shake that finger at me, be strong, be brave, do it for me, she would say. At the conclusion of treatments, I wanted to go on with my life. I didn't want to think about cancer. I didn't want to talk about cancer. I wanted to be normal. No, I needed to be normal. I asked my family not to ask about it. Julie, how are you doing today? Was not allowed. Um, I would graduate from high school. I don't know how, being gone for 3 months, but they graduated me. And I went on to a technical school around my home, knowing that I couldn't leave my caregiving system, and got a dual degree in computer programming and accounting. And I became a school chief financial officer, public school chief CFO. Over the years, most of the friends and co-workers that I had didn't know about my cancerous past. But I realized that those very crude treatments that had saved my life were going to haunt me for the rest of my life. The first and absolutely most devastating realization was the ability to bear children was gone. Those dreams of a picket fence and the husband and the career, they were all gone. All we wanted was a little more time. Give me some more time. Because of the removal of my spleen, I have a compromised immune system, unending back pain that haunts me every day. As a result of my immense scarring on my chest and lungs, every cold, every flu, every bug hit me harder than anyone else. My menstrual cycle stopped because of the radiation to my pelvic area, resulting in bone density issues later in life. I have a heart valve issue now, and in the past year, I have experienced ongoing issues with my thyroid, throwing me into orbit. And one very significant thing is the mental stress with the fear of reoccurrence that never goes away. Any ache, any pain, any fever, I knew it was back. There was a dark cloud looming around me. Cancer would once again upend the Alexander family when in 2007, my mom was diagnosed with terminal cancer. I became the caregiver and she was the patient. I tried so hard to be the caregiver that she was for me. I sat by her bedside every day, and I tried to knit and tried to crochet and do all the things that she helped me do, pass the time. But I have some of the most lovely memories of those 6 weeks before cancer took her from me, because it was a time when my sisters and I could spend time with mom and really, really bond. Sue Amy and I decided that every year we're going to get together from South Carolina, Ohio, and Indiana, and we're going to do a craft project in honor of my mother. And we do every year, and we laugh and we cry and we eat and we drink and we make these wonderful crafts that I peddle at all of my ACS functions. Now, on to medical care. I think for the first 40 years after treatment, I had what I would call good care. I was comfortable with my medical team, my oncologist that I didn't see very often at that point, but my primary care physician, my gynecologist, even my dentist. I had some issues with my teeth. But never did I feel that the docs were addressing, instead of a 40-year-old woman with a thyroid issue or a 50-year-old woman with osteoporosis, I thought I should be seen as a cancer survivor with residual issues of treatment challenges. My docs rarely never made that connection for me, because it was so long ago. I had no survivorship plan, no 101 survivors. I was left to guess and assume, and I guess secretly, maybe I did want them to just leave it over here and don't address it. Um, but I know that they should have. And luckily, I was able to speak at a survivor symposium at the University of Cincinnati, and I met the most wonderful specialist in cancer survivorship. And I thought, I was intrigued. This is great. This is so forward thinking when I met Dr. Erickson. And that very first appointment with Dr. E was more than an hour and enlightening. I would learn direct correlations between my treatments and my current conditions. And quite honestly, I didn't really want to hear everything that she told me, but I listened very intently, very cautiously. And I would realize that I'm at greater risk for developing still other issues, even at 67. Even with that uneasy realization, I immediately felt a sense of being at home. She gets me. She understands what I'm going through. She made me comfortable and at ease. And I am more than appreciative of that. And we have a great relationship now. I think I am a little more proactive rather than reactive. And I feel that I can get the answers that I need right now when I need them. I want to backtrack just a little bit. In 1996, I was asked to join a local American Cancer Society Relay for Life. I would attend the event with my superintendent, who had been just diagnosed with testicular cancer. And on a registration box, I cautiously is not a good word. I reluctantly checked that survivor box because he didn't even know I was a survivor. And when I got to the event, they gave me a purple shirt that said survivor on the back. I was so excited. I was able to walk that very first survivor lap with champions. And Bob and I were hand in hand, and I felt this euphoria that I was once again slaying the cancer dragon. And I guess from that point on, you could say I was hooked. For years, I did bake sales and garage sales and car washes and lap donations. And Relay for Life evolved into an opportunity to go to Washington, D.C. I thought, they're giving me a purple shirt every year. Now they're sending me to Washington, D.C. This is great. My first meeting with an elected official was Congressman Dave Hobson, and it was epic. I was so nervous. I had hives. He could see all the hives. He had his staffer go get me some water, but I calmed down and I spoke to him for a long time about my story and my feelings and how important it was for my elected officials to properly fund cancer research. And when I left some 45 minutes later, with a shake of the hand, he assured me that he would cross party lines and vote for a $2 billion increase to cancer research through the NIH. That big hook got me again. And I've been back to Washington, D.C. every year for the last 20 years. And last night at 8 o'clock, I returned home from my visit. We asked for more funding for research. We asked for multi-cancer early detection coverage for folks on Medicare, which I am. And this would you probably all know this, but test for multiple cancers with one simple test. And it's in the pipeline with the FDA, and we want to hit the ground running. When it's approved, folks on Medicare can have that if their doctors say it's a medical benefit. We also talked a little bit about the tax credit that's going away next year on Obamacare and the need to keep that a constant and not let that go away. I just can't tell you how important it is for me as a survivor to pay it forward for other people to have the best possible care. I encourage my elected officials here at the State House in Ohio and in the halls of Congress to appropriately fund cancer research, increase tobacco tax all tobacco products at the same rate, multi-cancer early detection tests, PSA screening for the most at-risk men, palliative care, which I had none, smoke-free environments, available, affordable, adequate, accessible insurance for all, clinical trials that include diverse populations. We are going to cure cancer for all. We have to have all of those folks involved. Copay accumulator, which is an exception that insurance companies make, actually did affect me because of Prolia injections that I took. Amgen, the maker, gave me a debit card for $1,500 to help pay for those tests. And unfortunately, my insurance didn't count it in my out-of-pocket maximum, so it was virtually useless to me. In Ohio, we're working on biomarker testing coverage. We always talk about breast and cervical cancer programs for uninsured women. We want to target childhood cancer treatments and, of course, prevention and cessation. And as I think about my time with my elected officials, and hubby says, Julie, you've just got to slow down. It's just not in my blood. It's just not in my makeup, because I feel maybe, just maybe, I survived cancerous grip to grow up and advocate for others. It's hard for me to grasp the statement that not all cancer medical decisions are made in medical facilities. Rather, many of them are discussed and made in the halls of Congress. So much legislation just makes sense to me. And as a long-term survivor, I can tell them how it affected me, how the research from in the early 1970s saved my life, gave me my entire life. So it's just a joy to pay it forward, and it truly is a joy to be with you today.
Oh, there we see your face. Thank you so much, Julie. And it is so nice to see you again. I heard
Oh
you
gosh, I'm
speak
sorry.
before when I was in Cincinnati for training with the American Cancer Society. So you're always an inspiration, and thank you for all that you do for the American Cancer Society.
Thank you so much.
All right, up next, it is my pleasure to welcome our first presenter, Dr. Lainey Francis. Dr. Francis is a medical oncologist and hematologist practicing at the flagship of UPMC Hillman Cancer Center in Pittsburgh. She sees patients with a broad array of solid tumors as well as hematologic disease. She is co-lead of a newly re-envisioned cancer survivorship program at UPMC Hillman Cancer Center, as well as the founder and director of the Wellness Integrative Oncology Program at UPMC Hillman Cancer Center. Dr. Francis has been named one of Pittsburgh's best doctors since 2017. She lives in Pittsburgh with her husband, Dr. Ely Francis, and her 3 boys. Dr. Francis, you now have the floor.
All right. Hi, everyone. I will never get used to this, like talking into a void. I definitely like the energy of an actual audience, even though this webinar situation is amazing, and ACS and all of their preparation and detail is really inspiring. But just letting you know, it's a little bit still awkward to talk into this green light on my computer. But hello, thank you for having me, and I'm really excited to talk to you guys a little bit from where I'm sitting currently while reflecting on my past, to talk about this space of survivorship, which I'm thrilled to be sort of newly involved in. In the couple of minutes that I have to present independently, I want to talk about 2 things, which is an overview of survivorship efforts at UPMC to date, and then a really exciting new initiative where myself and Dr. Katie Schmitz are working very hard to re-envision survivorship at UPMC. And it's very interesting to be talking with all of you because we're looking and thinking really hard about all the amazing work that's come before us, as well as some of the struggles that are coming at us, and trying to design a survivorship effort that really starts to be reactive and iterative to the healthcare system that we all live in. So with that, this is a brief overview, and I'm going to start by talking about some efforts at UPMC just to lay some context. I can take the next slide, Shauna. So before I came onto the scene, there was very robust survivorship efforts at UPMC. And I think it's important to note that we've all been working really hard at this for over 2 decades now and trying to find the right fit, both for our patients, both for the research, and both for ourselves as providers. And what was going on at UPMC on one landscape was a survivorship program called Live Well. It was run by Dr. Josie Van Lunden, a medical oncologist and geriatrician by training. And it consisted of 2 main sites, with the predominant site at our women's hospital of UPMC, McGee Women's Hospital. And there was a focus on breast cancer, a focus on coordinating ancillary services, and McGee is currently maintained as an active center. They have their own commission on cancer. However, it exists without any clinical programming. So that's just something maybe we'll get into in the panel, sort of how we're working on this and how the Commission on Cancer is participating. Next slide, please. We have an amazing children's hospital, and there is a very robust survivorship program there run by Dr. Jean Tursak, who is a pediatric oncologist and the medical director of the program. This has been going on since the early 2000s. She has a wonderful team. They focus on childhood cancers with the predominance of leukemias and lymphomas as their predominant cancer type. And they also coordinate ancillary services and serve as a consult-driven service for these patients who they're typically seeing once a year. Next slide, please. We're also lucky to have a very robust head and neck cancer survivorship clinic, which is run by a Dr. Marcy Nielsen, who is a nurse leader in the survivorship space. And this is a super successful program. It has a lot of research support. They do amazing data and analytics. They see head and neck cancer patients, a very, very difficult population with many, many needs, and work to coordinate some of those needs through different providers such as audiology, physical therapy, nutrition. And this program has also been chugging along for 2 decades as an excellent example of sort of subspecialty oncology survivorship care. Next slide, please. Thank you. So I just wanted to throw that out there. Many of our healthcare systems are large and sometimes somewhat fractured or siloed in the best of intents. And this is an example of coming in, looking at a snapshot of what has been working, not working, and then sort of Katie and I really trying to look at all of that, include all of that, diplomatically cheer each other on and lift people up, but also create a new survivorship offering with everything we've learned and everything that we're passionate and spirited about creating. So with that said, I want to talk for just a couple minutes about our plan at UPMC Hillman for survivorship. And we're sort of coding it SVX as a little tag name. It's also a lot to type out survivorship every time. But in this quick overview, I'm going to talk about my background and a little bit about Katie Schmitz's. I want to talk about the 4 pillars of our program and a philosophy that we are taking to push in on patients. And I'll explain that a little bit more. We are starting with a pilot in prostate cancer, which I'll give you guys some information on, and then finish with a general sense of our hopefulness and some plans and collaborations that we have in mind. So these are pictures of myself and Dr. Katie Schmitz. We are the co-leaders of our newly re-envisioned survivorship program at UPMC Hillman Cancer Center. And we are coming at this from two different backgrounds and angles. Dr. Katie Schmitz is an internationally renowned scholar and researcher in the field of exercise oncology. And she's also the founder and director of Moving Through Cancer, a program she created about implementation and study of exercise oncology. She has an amazing background and expertise in clinical research, in pragmatic intervention-based research through exercise, and that is a really exciting piece of our co-leadership. I am a medical oncologist, hematologist. I've been in practice for about 20 years. I've been in the Hillman Cancer Center space with a lot of colleagues and friends. This is my community. I'm a lifelong Pittsburgher. And I am also the founder and director of our Wellness and Integrative Oncology program. This is a program that's been around for about 10 years. It is a program that myself and my team sort of started from scratch with the intent to provide symptom management for patients with cancer with a more holistic approach. We have focused on movement, touch, nutrition, and mindfulness as our key pillars, and an effort to sort of see active cancer treatment and symptom management through an oncology lens and in a safe and supervised way, bring about hands-on holistic approaches. Our current program focuses on acupuncture, yoga and meditation, exercise, nutrition, and this is a very sort of deliberate approach to bring that to patients, help make it affordable and resource sustainable. And it's been an amazing and very popular program at UPMC Hillman. Next slide. So with that said, I want to just take a couple minutes to show you these 4 pillars, which are the structure of our newly re-envisioned survivorship program. The 4 pillars that we define as non-negotiable for every cancer patient, every cancer survivor, and we are defining survivor at diagnosis. I'm sure we're going to get a little bit more into that in the panel. But the first pillar is exercise, and that is exercise oncology. That is a field of Katie's leadership and expertise, and that is also embedded as Moving Through Cancer, a deliberate program to get every patient exercising in a way that works for them. Similarly, a second pillar that we feel is non-negotiable is nutrition. And I call this lifestyle nutrition because this is less about medical nutrition and calories and tube feeds and more about the nutrition questions that patients have. Nutrition is overwhelming. There's a lot out there in the lay press, in the media, in the world. There's different diet fads. There's different diets that work for people. And then, of course, on top of that, there's the symptoms of cancer and cancer treatment that affect how things taste, how things feel. We know that obesity is a major risk factor for several cancers. We want to work towards a collaborative approach to food and in a way that brings food joy, it's family, it's nurturing. So the lifestyle nutrition component is a very, very important and exciting part of our program. The third pillar is really folding in this integrative oncology effort that we have been very successful at, but looking at it as a way of self-management for symptoms for patients that want less pharmaceuticals and a more holistic approach. So the vision is that the integrative oncology will be a way for patients with ongoing symptoms and struggles, pain, fatigue, neuropathy, to say, okay, I've tried a medicine, it works, it doesn't work, but what are ways that I can live with this, move forward, be proactive, have my own control over this, and use holistic and integrative tools for it? Most notably, I would say meditation, yoga, acupuncture, and probably massage are our main focal points of the integrative oncology. And then finally, the fourth very important pillar is medical surveillance. So this is sort of what maybe some of us think about as survivorship and survivorship clinics. This is the surveillance to detect a recurrence, surveillance to detect secondary malignancies, all of the subspecialty care that patients may or may not need after cancer treatment, such as cardio-oncology. And very importantly, something that really jumped out at me as Julie was talking, and obviously as others talk, the fear of recurrence. How can we assure patients in these survivorship visits that in that moment, we feel they are free from cancer, they are safe, they are doing well. How can we make those visits really punctuated by clean, deliberate, evidence-guided medical surveillance for survivorship? So those are the 4 pillars which we are thrilled and excited about. Next slide. So another interesting thing, aside from the 4 pillars that Katie and I are very focused on, is this notion of pushing in on patients. I think with integrative oncology, we have, in many ways, allowed patients to come to us. It takes accountability to make lifestyle change. Patients are very overwhelmed with multiple appointments. Sometimes they can't follow through as much as they'd like. And we have sort of allowed that to work for us in the sense that the patients that want to come will come and get the benefits they want. But the survivorship program, and much of this is Katie's influence on me, is we are pushing in on patients, not waiting for them to come to us, not waiting until treatment is complete, but really trying to describe these benefits of exercise, nutrition, symptom management, and push people a little bit, which I'm very excited about. It's not a super comfortable space for me, but I'm super interested in what the panel has to say about this concept. We are combining forces, of course, as a clinician and a researcher. We want to fuel a wheel where patient care drives research, and those patients participate and contribute to research to change the standard of care, whether that be in exercise like Katie's done, in nutrition with all the ideas that we have, in integrative oncology based on a clinical program that's been so successful. The combining forces and the wheel of research and clinical care is super exciting to us. And then finally, we're collaborating with the Cancer Cabinet, a part of the Cancer Moonshot. Both Katie and I are on the expert panel for the Survivorship Working Group. And so we're really reflecting all of what we're trying to do in real time with an ongoing effort to create national standards for cancer care from the NCI through that Moonshot effort. Next slide. We're beginning with a pilot in prostate, and I can get more into why we chose prostate if that's something people have questions about, because I want to be responsible with time. In a nutshell, it's an enormous and heterogeneous population of cancer survivors. The benefits of exercise and nutrition in this population have been demonstrated and are well respected. And cancer patients with prostate cancer are survivors of so many different effects: cancer surgery, radiation, hormone therapy, chemotherapy. And we also have a very strong and solid group of colleagues that are excited to work with this on us with this. So that's sort of one of the reasons that we're tapping into the pilot with the prostate cancer population. We can wrap up in 2 minutes. Yeah. So this is a little bit of our prostate pilot. If people have questions in the panel, I can get into what we're trying to do. We are starting with a survey. We're asking questions about our 4 pillars to risk stratify for exercise, nutrition, integrative oncology, and surveillance. A nurse navigator will reach out. We'll work on sort of a prescription for survivorship. We'll have a database that we can reflect upon for research. And then importantly, we hope to replicate this, create sort of a modular return on investment and financial plan so that our institutions and others can say, this is what it takes to run a subspecialty survivorship program. It takes a half an FTE of a nurse practitioner, a half an FTE of a nurse navigator, this many dollars per year, so that we can stop with this sort of jack in the box of no one wanting to pay for this or struggles to pay for this, as the institutions should really be collaborating with us to take a strong source of leadership on payment. I can take the next slide, and this is just some ideas for our plans and collaborations, a symposium, ongoing pilots, new pilots in new populations, and I am open to ideas, and I will stop now due to time. Thank you very much.
Thank you, Dr. Francis, for that great presentation. Our next speaker is Ruche Hatfield. Ruche is a nurse practitioner working in cancer support care, cancer survivorship. She sees survivors of all types of cancer, but most patients she sees are breast cancer survivors. She has been practicing as a nurse since 2005 and as a nurse practitioner since 2012. She began caring for oncology patients at the James in 2008. Prior to coming to the James, Ruche served in the United States Air Force, where she cared for persons on active duty, their families, as well as veterans. Welcome, Ruche.
Good morning. Thank you for the introduction. I'm really happy to be here to talk to everybody. Really exciting, Dr. Francis, to hear about what's going on in Pittsburgh. And I wanted to say thank you to Julie, too, for sharing her story. Really inspirational. So I just wanted to talk a little bit today about my role at the James in our survivorship program and just some of the services and about our clinic and what we do. So I can take the next slide, please. Actually, just predating this Commission on Cancer program standard first. This is kind of the evolution of how I came to be and working in cancer survivorship. But prior to 2016, when the standard was developed by the Commission on Cancer here, really, there's a whole history and evolution of cancer survivorship. But in 2006, there was this really landmark report that was published by the Institute of Medicine called From Cancer Patient to Cancer Survivor, Lost in Translation, and it really kind of just highlighted, it was the first document to do so, formally highlight the needs of cancer survivors. And so kind of subsequent to this report, different organizations, Live Strong, National NCCN, American Cancer Society, but started developing different elements that they felt were important or necessary in cancer survivorship, different guidelines. And so in 2016, the Commission on Cancer adopted this standard 3.3 that included this requirement that a comprehensive oncology cancer treatment summary and follow-up plan be provided to all individuals that are receiving curative intent therapy for the cancer. So, and as a result, and to keep accreditation, programs quickly began trying to implement different processes in an effort to achieve and maintain their accreditation. And they used different varieties of methodologies. So might have been use of health navigators, APPs, such as myself, we used electronic health records to collaborate and deliver these plans. So this was like late 2016 that the survivorship program at the James really started to grow and develop and evolve more than it had been prior to that. Myself and a couple other nurse practitioners were hired really, and the focus a lot being on these creation and delivery of treatment summaries and care plans. So ASCO developed this treatment summary survivorship care plan, said there were these core set of data elements that were to be used as part of the treatment summary and care plan. What we kind of realized as time went on, I'm so sorry, I keep forgetting to tell you to advance the slides. Next slide. I'm sorry, I go back one if you would. So here's ASCO's treatment summary and survivorship care plan, just their core elements that you can kind of see here. So general information, including like the patient's care team. You've got information about their treatment, so their cancer type, their diagnosis, stage, surgery, chemo, radiation, adjuvant systemic therapies, genetics information, information about like ongoing care needs, coordinating providers, common side effects, possible later long-term. So that's just sort of the core set elements that ASCO developed to be part of these treatment summaries and care plans. Next slide, please. So as I was saying, kind of as time went on, realizing there are some barriers. Treatment summaries, care plans are very time consuming to prepare. There's sort of lack of clarity on who should really be responsible for completing and maintaining the information that's necessary to go into the treatment summary. Should it be the surgeon? Should it be the medical, radiation? Should it be the nursing teams? And really also just lack of reimbursement. So, and there still really isn't, for the time that it takes to create these treatment summaries and care plans, reimbursement. So that's sort of a barrier too. Next slide, please. Something else that kind of came out of, let's get these patients, we need to create this document that has a summary of their treatment and its care plan. So the original goal with the treatment summary is to facilitate and to enhance survivorship care for patients that are completing their cancer therapy. Also to engage patients, to engage members of their care team in the knowledge of the treatments that they received and what their risk is for different potential late effects, what are recommendations for screening. So really just like an opportunity to engage, educate, empower patients. But instead, this focus really kind of diverged and became on providing this document and less on the importance of delivering actual quality survivorship care. Next slide, please. So in 2020, when the COC updated their standards for survivorship care, they sort of eliminated the requirement for the provision of a treatment summary and care plan. So it's still recommended, but it's not a requirement to maintain accreditation. And so really hoping with this that the emphasis on the actual process of delivering survivorship care by a team of providers, that the focus can be more on that. However, sort of a risk too might being that there's less emphasis on survivorship care as a whole, and that if there's not still some time dedicated to the treatment summary, care plan, and education, then individuals might lack knowledge surrounding their treatments, their follow-up, risk, sort of follow-up recommendations and risk for late effects, which are some of the things that were initially emphasized in the initial Institute of Medicine report that resulted in those requests for treatment summaries and care plans to begin with. So it's really kind of finding this balance. There's a really nice article, I included the link here too, that I think it's compares the Commission on Cancer's requirements and sort of the verbiage that went into the 2016 standard versus what they updated with the 2020 standard that I would refer you to. It gives a nice overview. Next slide, please. So I kind of have a dual role as a nurse practitioner in survivorship clinics. So I still provide a lot of treatment summaries and survivorship care plans to patients. I would tell you most patients are really appreciative and really appreciate having that document and spending the time to kind of go through it, and then it's being communicated because I do send it on to their primary care provider and any other providers that they wish to have it sent to. Another part of this visit, though, is I'm doing a really comprehensive supportive care needs assessment and letting patients know about resources that James offers, making recommendations, providing education. Next slide, please. So this is kind of what a visit with me looks like. We have a very APP-driven clinic. It's myself and a handful of other nurse practitioners. And I said my experience is mostly in breast, so that's where the majority of my knowledge lies. But I do see patients of all different types of cancers. My visits are scheduled for an hour, so really have time to delve in to all the different things that we want to talk about. And we're just having a conversation with the patient. I always tell patients it's very informal, like this is a discussion for us to have. If you have questions, concerns, please just interject them as they come up. We're trying to cover all aspects of how they're doing, not just physically. How are they doing emotionally, spiritually? Are they having cognitive concerns? Are there practical issues? And then discussing goals that the patient might have for optimizing or improving their health and well-being, providing education, so talking about the importance of healthy lifestyle habits, other age-appropriate cancer screenings, health and wellness, and then getting patients plugged in with all the different supportive care resources that we're really fortunate to have at the James. Next slide, please. This is just sort of an overview that there is a really wide spectrum of potential side effects. I see them out there. I'll try to wrap it up. That patients might have. Some of them are really realized very quickly as they're undergoing treatment. Some are things that might come on later after treatment is completed. Next slide, please. As far as like overview though, here late long-term effects, 50% of cancer survivors will have at least one of these later long-term effects, sometimes temporary, sometimes chronic, but these are the top three things. And I'd say from experience, these are, yes, these are the things. Fatigue, very common, psychosocial issues, depression, anxiety, uncertainty, fear of recurrence, and pain. Next slide, please. This is a supportive care screening tool that we utilize that was developed by one of our psychologists at the James. As you see, it kind of breaks down and asks patients about how much they've been distressed or bothered. And it has kind of general categories of emotional, spiritual, et cetera, and then breaks it down even further. And we just ask them to rate their distress from none to severe. And this kind of helps helps us to target our visit a little more about the things maybe the patient's more concerned about or could use support in. There are other resources out there too. NCCN has like a distress tool that can be utilized, and I'm sure there's others as well, but this is the one we use at the James. Next slide. I guess I kind of spoke to this a little bit, just kind of the purpose of a treatment summary and care plan. Really, the person composing it should be completed by the institution or office where the oncology care was provided. I think it's most ideally given in the first 6 months of active treatment completion. I mean, that's when a lot of times patients have kind of finished the focus on the treatment, what's next, and then thinking about a little bit like what comes after. This should be a real-time discussion, interactive, shouldn't be something that's just like prepared and sent to the patient without a discussion. Next slide, please. Really needs to be personalized to the patient, should include the different details of the treatment they received. We try to use this like as plain and non-clinical language as possible. Some of the other elements here, which I think I kind of covered a little earlier, we can kind of skip over. Next slide, please. This is just sort of an example of the James kind of what's developed. This is the general template. We have different smart phrases that we utilize for even every different like disease line to talk about like late and long-term effects and follow-up and things like that. So it's really personalized to each patient. Next slide, please. This is just a very brief example of what a breast one looks like. So it's kind of said like, oncology visits, what's the surveillance that's appropriate, other cancer screenings, kind of who the coordinating provider should be. Next slide, please. You skipped one, but that's okay. I won't go through all of these. These are just a lot of the different supportive care services that are offered at the James and some of the different indications that we'll often be referring to them for. And we're fortunate to have a very robust the amount of like supportive care services that we have at the James. So there's actually the next slide too. So that being said, I'll wrap it up. Thank you for your attention. I think that's my
Thank you, Ruche. That was so interesting. Our next speaker is Dr. Melissa Erickson. Dr. Erickson is currently an adjunct assistant professor in the Department of Family and Community Medicine at the University of Cincinnati College of Medicine. She is the medical director of oncology, primary care, and cancer survivorship, and the Robert and Adele Schiff Family Clinical Endowed Chair for Cancer Survivorship. She provides primary care services for patients with active cancer, a history of cancer, or a genetic predisposition to cancer. Additionally, she sees adult survivors of childhood, adolescent, and young adult cancers in the Cancer Survivorship Clinic at Cincinnati Children's Hospital. Dr. Erickson, welcome.
Thank you. It's a pleasure to be here. And I thank the American Cancer Society for putting together this wonderful panel to help advance the care for our cancer survivors. So today I'm going to talk to you about something very near and dear to my heart. This is about the creation of an oncology primary care clinic to really address some of these needs that we've been talking about so far this morning. Next slide, please. So a little bit about how did I get here as a family medicine doc, right? So I went to med school here at University of Cincinnati, where I'm coming to you from today, completed my family medicine residency, and then really practiced general primary care for 10 plus years. But it all changed really in 2012 when my dad, who is kind of here in the center of this picture, was diagnosed with metastatic esophageal cancer. And, as many of you are probably aware, cancer affects not only the person with the cancer, but the entire family and surrounding supporting members. And so it really made me want to work with cancer survivors and really change the trajectory of what I did with my career. So back in 2017, I joined the Cancer Survivorship Clinic here at the University of Cincinnati, and then subsequently joined the Survivorship Clinic at our Cincinnati Children's Hospital. Next slide. But in doing all of this work, seeing these cancer survivors for these, survivorship visits, like our last speaker just spoke upon, I realized that there was a gap in care, right? That so many of my patients didn't have a primary care doctor. And this is despite, we have good evidence that says when patients are cared for by both an oncologist and a primary care physician, they get better comprehensive care. Their outcomes are better. However, when a patient gets diagnosed with cancer, the opposite often happens. They become disconnected from their primary care doctor. Next slide, please. Why does this happen? Well, some of this has, barriers associated with the patient, right? Many of them never had a PCP or don't currently have one. Sometimes there's a level of mistrust, right? It's not uncommon that a patient might say to me, I don't trust my doc because they missed my cancer diagnosis. Some of it's just education. They may not understand the importance of treating their comorbid conditions, or really unaware of some of the heightened risk for second primary malignancies that they may be at. Some of this is on the doctors, right? So studies have shown us that primary care docs have a low comfort level for caring for patients with a history of cancer. Julie, our first speaker who shared her inspiring story with Hodgkin's, Hodgkin's is a complicated group of folks to take care of, often related to the multi-modality treatment they've had with radiation, chemotherapy, and whatnot. So only a third of PCPs felt comfortable caring for folks with Hodgkin's. Only 16% knew the guidelines for breast cancer screening, and only 10% knew the guidelines for cardiac dysfunction, right? So we clearly have a gap in our education of our PCPs. And then some of it is associated with our cancer specialists, right? Only less than half of PCPs ever got any kind of treatment summary or care plan. And many cancer providers feel that there's a lack of confidence in their PCPs to really care for their patients. Next slide, please. So why do we think survivors need PCPs? Well, we know that they're at increased risk of cardiovascular disease. And not only that, specifically conditions like high blood pressure and type 2 diabetes are less well controlled than their non-cancer peers. I think, it's one of those things, fear of cancer recurrence is often, at the top of the list of our survivors. But in reality, for many folks, their risk of dying from heart disease is higher than that of dying from their cancer. We know that they have an increased risk of second primary cancers. Some of that is due to shared risk factors, but some of it's due to the treatment itself. Certainly, we can help address long-term and late effects from the cancer and its treatment, and health promotion, right? That is certainly in the wheelhouse of most PCPs. We're already, doing that to work to promote healthy living through nutrition, through exercise, through vaccination, et cetera. Next slide, please. So oncology primary care, this is kind of a newer concept that's being done at some cancers. Folks like Dr. Kevin Eppinger at Duke, Dr. Larissa Neklodov at Sloan Kettering have really been pioneers in this field and have helped kind of inspire what we do here at UC. And the goal is to provide comprehensive primary care for patients with cancer. And this care is provided by a primary care physician who has specialty training in cancer survivorship. Next slide, please. So how have we done things here at UC? We started this back in 2021, and adults who have a current or prior cancer diagnosis are eligible. And additionally, we see folks that may have a cancer, a genetic mutation that puts them at increased risk of cancer and requires heightened screening. We've had over 4,000 patient visits. About 40% are on active treatment, and a little over half have completed treatment. Because of our coordination with our children's clinic, about 12% of our folks have a pediatric, adolescent, or young adult cancer diagnosis. And amazingly, almost 80% have at least one cardiovascular disease. Next slide, please. So what is our clinic structure? This is a picture of part of our team here. We have 3 family medicine physicians. So in addition to myself, we have one doc who completed a palliative medicine fellowship. And our third doc did sort of a combined palliative medicine and survivorship fellowship with us. We have a nurse practitioner, a nurse, several medical assistants, a scheduler, and then we have shared resources. Being co-located within the cancer center just allows for more care coordination, as well as use of resources like our oncology social workers and our clinical oncology pharmacists. Next slide, please. So I wanted to highlight very briefly some other survivorship services that we also provide, because we can't do this, it's not just about our primary care team. It's a very multidisciplinary approach. We have survivorship consultations. Those are typically seen by our APPs, where they create that treatment summary and care plan that Rashay just talked about, and kind of getting them plugged into the various supportive services that we have, whether that be with our oncology dietitian, our integrative medicine services, such as acupuncture and massage. But another program that we're very proud of that we wanted to highlight is our Cancer Exercise Wellness Program. And this was really one of our inspirations for this program was Dr. Katie Schmitz, who Dr. Francis kind of mentioned and partners with at UPMC. And we house this in the cardiac and pulmonary rehab space. And so these folks are already accustomed to creating exercise plans and working for medically complex patients. And our exercise physiologists are cancer certified by the American College of Sports Medicine. So they understand some of the unique risks that our cancer patients may face while exercising. And then finally, I wanted to mention our cognitive cancer clinic. This is a partnership with our neurology specialists. And we know that a large portion of our patients have what we call chemo brain, or right, some cancer-related cognitive impairment. And so this is an avenue that we can provide neurocognitive testing, work up, make sure that we're not missing other medical issues, provide longitudinal follow-up, and kind of get them hooked into the appropriate resources, which often involves referral to one of our cognitive therapists. All right, with that, I am done, and we'll be excited to take any questions as part of our panel.
Okay, wonderful. Thank you, Dr. Erickson. Our final speaker will be Dr. Nicole Stout. Dr. Stout is a research assistant professor in the School of Medicine, Department of Cancer Prevention and Control at West Virginia University Cancer Institute, and with the School of Public Health, Department of Health Policy, Management, and Leadership. She also serves as the Associate Director of the WVU Cancer Institute's Survivorship Program. Dr. Stout's research focus is on the integration of healthcare delivery models into clinical practice that expedite identification and management of cancer treatment related morbidity. And you have the floor, Dr. Stout.
Thank you, and thanks for that introduction. It's great to be with everyone today. I will also just share with you some news and a caveat that yes, today in this role, I am a professor at West Virginia University, but as of September 30th, I have accepted the position of to be the Senior Director for Survivorship and Wellness at the American Cancer Society. So I will be joining this effort on a larger scale and in a much broader way. And so what I have seen and heard this morning, in my comments, I really hope to be able to kind of outline for us what we've heard, summarize where I think perhaps we could be looking to go by utilizing what you've heard and what you have learned today. And, you know, I put this slide and this comment out. And when we know that there is a confluence of circumstances that will escalate risk of an adverse outcome, do we choose to be proactive or are we reactive? Do we wait for impairment, disability, complications associated with cancer treatments, or are we proactive? And I would suggest that with cancer support and survivorship care, we have an unprecedented opportunity at the point of diagnosis to understand what the treatment plan will look like. Treatment plans for cancer medically directed care are relatively prescriptive and relatively outlined well at the point of diagnosis. Therefore, we can anticipate what treatments an individual will receive, when along the timeline of care. We can anticipate common side effects. We can anticipate how the downstream of those side effects will impact that individual's ability to participate in their life roles during and after treatment. So while I think historically we have been somewhat reactive in issuing care plans at the end of treatment, trying to talk about how to fix the problems after they happen, where I see survivorship moving in the future is towards a much more proactive, prospective surveillance type of an approach. And if you could go to the next slide. So if survivorship starts from diagnosis, then I think we need to start thinking differently, because we say things like, well, once you transition into survivorship, but survivorship needs to be intimately associated with the cancer medically directed treatment plan. So it needs to become a system of care. So I guess I say, isn't that now? Shouldn't we be thinking about these survivorship and support issues now? Go ahead. The other thing we say is, well, we assess for these needs and these problems once our patients get into survivorship. And again, I think if we're thinking more so about those things, go ahead and click. Yeah, if they're experiencing issues now, why would we wait? Right? These side effects of cancer treatment, and I guess when I say that, I think very broadly. Side effects include things like financial impact, sexual function, relationships, family, in addition to the neuropathies, the cognitive changes that we've heard about. So if those things are not waiting for our patients to get done with cancer treatment, they're happening actively in real time. They're negatively influencing their life while they move through cancer treatments. So if they're experiencing the issues now, survivorship as a system of care needs to intersect and help to support the patient now. And I think you've heard that woven through the themes that we've seen through these 3 fantastic programs. And you've certainly heard that from the patient that we heard from early on. Her story, Julie, was just remarkable. So thank you for sharing that. But I do think some of the struggle is there is so much around what we need to bring in to inform survivorship care. I think of it as an ecosystem. There's the medically directed care that needs to happen, surveillance for new cancers, managing physical and psychological symptoms that very much require a medically directed approach. Then there's health information needs, the things that help our patients to self-activate, help to change behavior and motivation. And really sometimes we need to give guidance, not just to give them information about their disease treatment, their side effects of treatment, but to really help to empower them and motivate individuals towards moving through and taking on that self-activation towards self-care and self-management. Sometimes, and as a provider, my background is as a physical therapist, it's really about enabling. How do I enable a patient to be more active? Giving them license sometimes and saying, yes, it is okay for you to go to the gym, lift weights, get back to work, get into an environment where you're doing these activities because it is very helpful. But how do I help them with the information to manage? And most importantly, how do we give them information to understand how far can they push things and who do they go to if they do start to have issues and problems? And we have a lot in the ecosystem here to help us. We have guidelines. We have a number of oncology societies, websites, organizations that have coalesced efforts to provide not only the information about managing these conditions, but also to create this network of support. And that's really the last part of the ecosystem is how do we maintain these supportive services, things that enhance the individual's ability to return to the activities of daily living, return to their work roles, and to participate in life. And what I love about all of the programs that you've just heard from is that each of them encompass different parts of this. I really believe that going forward, we have to think about creating a large tent. Survivorship isn't just a care plan that's given to patients as they finish treatment. It isn't just a connection with a clinic or a physician or even with a primary care physician. It's a system of care and it encompasses the needs of individuals who are adolescent, young adult, pediatric survivors. It encompasses the needs of geriatric oncology. So we think about this large tent, bringing everyone into this large tent and understanding what we're doing with AYA initiatives, what we're doing with the geriatric oncology initiatives, physical activity guidelines and exercise, primary care. How do we distill down the very common baseline elements? What's the common denominator across all of these? We need to better understand needs. We need to meet those needs when they occur. So it's getting the right service to the patient at the right time to meet and alleviate the need. So conceptually, I think we all get that. Conceptually, we say, I understand cancer survivors. There is a growing population. There are so many needs. There's a high level of disability related to potential late effects. And go ahead to the next slide. But really, how do we then say that survivorship care is a part of cancer care? And so we should really be thinking about how do we implement processes for needs assessment from the point of diagnosis. And you've heard some ideas today, operationalizing patient-reported outcomes measures in your EHR, operationalizing distress screening in your EHR. But we don't just want to assess those needs, we want to act on them. And that's critical. We have got to stop, as I like to say, we've admired this problem and the needs of cancer survivors. We have characterized it, we've documented, there's so much published about the gaps in care, the needs. How do we begin to act on these things? So we want to utilize clinic tools, our workflows, to help to optimize connections to the services that patients actually need. So some of the things that I've heard in the discussion here today are really incredible. I like the push in concept that University of Pittsburgh is talking about. In West Virginia, we've created what we call an opt-out model. And so all of our patients are opted in. If you could go back, thanks. All of our patients are opted in to our survivorship care continuum. We have workflows that have been put into our EHR. And what it really does is it puts the specialist in an interface with the patient so that they can have a discussion about the needs. Rather than relying on the patient, we ask the question, do you want to see a social worker? You checked this box. Do you want to go for a consult with our cognitive therapist? Instead of putting that burden on the patient to say, well, I don't know, you tell me what I need. We do that. And what we then do is we empower patients through providing them with that information, self-activation, and getting them moving towards understanding the role of each of these different specialty services. So I like that idea of the opt-out, or the putting the co-location, as it was also described. Co-location is critical. These individuals don't want to go to another site, meet a different provider, have to go somewhere where they don't know where to park, how they're going to get there. So as we think about this, again, survivorship care is cancer care. It needs to be a system that is very much aligned. Lucky for us, and in a very timely way, what we've just described here, right, are how do we create the processes, the policies, and then look at the important outcomes. And now go ahead to the next slide. And we have a very newly developed standards that have come forward through a consensus discussion to really look at what are the standards that should inform quality care. And if you look at these three buckets, and this is available to you through the article in Journal of Cancer Survivorship, but also this is a part of the National Cancer Institute's Office of Cancer Survivorship webpage. We are looking at what are the health system policies, health system processes, and the health system evaluation and assessment, the outcomes. So while each of these organizations have demonstrated these beautiful models, I think some of the comments that came across was in healthcare, in medicine, in oncology, we work in silos, whether it's a disease team, whether it's a clinic, medical oncology, radiation oncology, the lung team, the breast team. By working through at the level of the health system, we can begin to incorporate policies and processes that can help us transcend each of those silos and get to distill those very basic needs across each of those areas of practice for all of our patients, agnostic of the disease type, agnostic of the vertical that they're in or the disease team that they see. So I think that's where we want to be thinking towards the future. How do we think about multi-level approaches that influence patients, providers, clinics, but also health systems? This needs to be implemented and supported at the system level. And that means prioritizing and changing clinic workflows, prioritizing and changing financial incentives and structures, information technology infrastructure. You heard about bits and pieces of all of those today. And so each of those elements really need to be tailored specifically to help to inform how you can do this within your specific practice. Go ahead to the next slide. And there are a couple of resources I would guide you to. Again, the Journal of Cancer Survivorship that released a special issue back in the spring of this year that really shared a history of cancer survivorship centers. It looked across several large academic medical centers and really describes the nuts and bolts and the components of survivorship programs. keep in mind there is no one size that fits all here. Understanding your specific clinical context, the resources you have, what will work in your system, those are the critical pieces that can help you to pick and choose from the menu of services, processes, policies that can help you to implement into your system. And also an implementation pathway. This paper in JCO Oncology Practice that I led with a pretty esteemed group of survivorship researchers really lays out how to use implementation frameworks and framing to help you think through that context, identify metrics of importance, and really get to that health system level approach to implementing survivorship care. So I really appreciate the opportunity to join you all today, potentially looking at going forward and how we can look to partner and to improve upon this and continue to work together for better outcomes for our patients going forward. So thank you.
Thank you, Dr. Stout, and welcome to the American Cancer Society. All
So
right, it is my
excited to be a part of it. I'm so excited to get going. So thank you for this opportunity today to meet us. Yes.
Of course. So it is now my pleasure to introduce our panel moderator, Dr. Sherry Young. Dr. Young was appointed Secretary of the West Virginia Department of Health by Governor Jim Justice on May 24th, 2023. She previously served as the Associate Chief Medical Officer to the Vandalia Health Network and Executive Director and Health Officer of the Kanawha Charleston Health Department. Welcome, Dr. Young, and thank you in advance to our amazing panelists.
Thank you so much, Liz, and thank you for all of our wonderful presenters today. The discussion from the American Cancer Society and bringing up this important discussion about cancer survivorship. So it is my pleasure to be here and to be hosting the panel with these wonderfully talented people that I have absolutely learned so much from today. First of all, we do have a question in the chat. I'd like to pose this either to anyone in the audience or to any of our experts on our panel, but we do have a question. Does anyone know about resources of oncology primary care cancer survivorship in New York City or the New York City area? If our panelists are aware of any programs, I know most of us are from West Virginia, Pittsburgh, and Ohio. So if not, if there's anybody aware of anything that we can share in the chat, please do so. If not, we can try to research that with our colleagues after the fact.
Yeah, and I'm happy to answer that. I am not aware off the top of my head, but I think I'd be happy to kind of research that and post any information that we might find.
All right, thank you so much, Dr. Erickson. So we will be in touch with that question regarding New York City area and hopefully making that connection. And Dr. Erickson definitely being a great primary care role model for that. So thank you for volunteering. So I'm going to start with some questions and we'll go around the panel. And first, I'd like to start with Rashay. What are some of the key challenges patients face when transitioning from active cancer treatment to long-term follow-up care?
Yeah, for sure. So I think a couple of things like largely broadly come to mind for me. So I think management of treatment-related symptoms, whether those are things they're still dealing with from the treatments they received, like chemotherapy, radiation, recovery from surgery, or with adjuvant treatments, depending on the cancer type. As I said, a lot of my experience is in breast, so I have a lot of patients that go on like hormone suppression therapy. So they're having like vasomotor symptoms and joint pain and things like this. So I think that's one of the big challenges is just kind of helping patients to navigate through and manage those side effects of treatment that can have an impact on, their day-to-day and their quality of life. And then the other big piece is the psychosocial aspect, I feel like, which is huge. Whether that's, and a lot of patients come in with like pre-existing depression or anxiety issues too, that are just like magnified or exacerbated by their cancer diagnosis. But really, regardless, anybody who's had a cancer diagnosis and gone through treatment always has a little element of uncertainty and fear of recurrence. And so I think for everybody, patients just kind of normalizing that, like, hey, it's very normal to feel that way. And then talking about ways that we can support them. whether that's through specific resources that we offer, mental health providers, getting them linked in with peer support, things like that. Other thing is just educating them on what to be looking for. A lot of patients are like, well, how am I going to know? Like, what is it that I should be looking for? And so taking that opportunity to really be like, these are the things that you can be looking for to bring to the attention of your providers if you're worried about. So those are the kind of the few things that came to mind for me in that realm.
Great, thank you. Wonderful answer, and thank you for your work in cancer survivorship. Next, I'd like to highlight our 49-year cancer survivor, Julie. You are such an inspiration to folks, and not only are you taking that and advocating and giving all of that back, I can feel how grateful you are just in the conversations that we've had. And so, thank you for your work in this space. But here's your question. So, what are your thoughts on the term survivor and survivorship? Is there another term we should be considering to describe how these programs and how this affects our population?
I guess my response is, for the first 20 years, I would not have considered myself a survivor. I think that in my adolescent mind, I wasn't a survivor until way after treatments were over. And I do think that at some point in time, when I was a little more mature and forward thinking, the term survivor became sort of a badge of courage for me and something that I became very proud of. I'm proud to tell folks that I'm a 49-year survivor and give hope to people for longevity after cancer treatments, especially when treatments were crude, and stage 3 in 1975 was pretty scary. I can tell you all that very much. I do know that some of my peeps that are advocates with me who are still going through treatment like to be called thrivers rather than survivors, because they don't, again, consider them a survivor until they're completing treatment. But I think that the word survivor can become something very strong if you allow it to be.
What a wonderful answer. Thank you, Julie. Thank you for sharing that. For our next question, I'd like to call on Dr. Stout. And so the next question, how can survivorship care plans be effectively utilized to support patients in long-term follow-up? And what sort of things make an effective survivorship care plan?
That's a great question. I'm going to just also sort of dovetail my answer onto what Julie just said. And what I think is historically, we've used the word survivorship as an end of treatment transition, right? Lost in transition was all about that. People are lost after treatment. I think we need to change the conversation. As we say, survivorship starts at diagnosis. We need to walk that walk. So what can a survivorship care plan look like? It can be a more active, dynamic process by which we track and actively identify the treatments that an individual has received, the side effects that they experience, the anticipated long-term and late effect follow-up. Alongside that, reinforcing to the patient that this is the way we manage your cancer. This is the way we do business. It's an active process of learning, tracking, giving them the information. Julie, you just made an excellent point, right? It wasn't so much that the information wasn't there about your disease or your treatment. It was, who do I go to, right? After, who do I touch base with to figure this out? Our patients going through active treatment have those exact same questions, right? They're fearful to say, well, my husband lost his job. I'm at risk of my insurance expiring, and we might get our electricity turned off, because they don't think that's the problem of the medical team. And as we know, again, with a big tent and a big perspective, all of that contributes to how patients experience, respond to their cancer treatments, and experience outcomes. And so I think a survivorship care plan needs to not only be this static document, it needs to be an active approach by which we track, monitor, offer support. The other thing that I'll say about that quickly is the handoff to primary care is incredibly important because that, in many instances, is the trusted provider for the patient, right? It's their primary care. If they've got one, they've been with them for a long time. When we talked with our primary care providers, they basically said all of them that we interviewed, they'd never seen a survivorship care plan. They had never seen one. So we spent a lot of time creating these documents, attaching them as a PDF file on our notes, and nobody looks at it. So process-wise, really thinking about how do we make that, again, an active approach, integrating with primary care, keeping them in the loop throughout treatment. Many of them don't know what's going on until the patient's done. So the entire thought process around what does a survivorship care plan mean? It should be a plan of care that is active and iterative and engaging the patient and other subspecialists as well as their primary care, not just sort of a recap of what we're doing and what we've done as a documented part of the record. That's important, but again, expanding that to be more.
All right, thank you, Dr. Stout, and congratulations on your transition.
I was going to say something just about this kind of plays into both the last questions, but the term survivorship and our clinics being called survivorship. And I mean, that's the way we're identified as James. And I don't always love it because patients don't really understand it a lot of the time. But I always like to introduce when I see patients like, welcome to our cancer supportive care clinic. So also known as survivorship, because really I feel like that conveys a lot more of what we're doing and offering for patients as supportive care as it relates to their cancer experience. So I feel like that term is maybe a little bit better or preferred compared to like a survivorship clinic. And then also just really to speak to Dr. Stout and talking about being more like, I love the proactive versus the reactive. And historically, and as I kind of got into my role, very much, we were always seeing patients end of treatment, giving them this document, kind of going over their summary and their care plan. And we're really trying to make a movement more towards seeing people early in treatment. It's hard sometimes to get the word out there, who we are, what we do, get the referrals, and letting patients know that we're there and they can self-refer. But I think it is important to be trying to capture people earlier. And we're doing it through a couple of our programs for sure, like our breast. We have kind of a pilot, and our pancreatic group too, just to capture people early on to do that supportive care needs assessment. And sometimes people really don't know exactly what all their needs are that early on too. So just to say, like, these are the resources that are available to you, I think is so important, and to offer myself as like a touch base, as someone they can come to with questions or concerns for all that other stuff that's outside of their treatment appointments. So anyway.
Yeah, that language and terminology is not terribly different than what we have seen palliative care transform from probably in the last decade, 2 decades or more, because palliative care used to just
End
be
of life.
this
Yeah.
end of life. Oh my gosh, you want me to go to palliative care? I'm dying. That isn't what it means. It never was intended to, but that was how we utilized it. So again, we changed the conversation there. We can do that here. To your point about the care plan and iterative assessment, repeated assessment, it's critical. We cannot just assess needs once. That individual is a very different person in 3 months, in 6 months, in a year, in 5 years. So this ongoing iterative use of a care plan, needs assessment broadly, I think that's the way for us to characterize and think about how we go forward being more proactive.
Great discussion. And words have meaning, and the term survivorship, that's definitely a great point and a great discussion. Thank you guys for your work. Kind of building off of that, and kind of an impromptu question: if you're taking self-referrals and patients aren't aware of that, what are some ways that we can partnership? And you have a national audience right here. How can we help get those referrals in the hands of patients so that they can self-refer, or in front of primary care physicians to make those referrals?
Yeah, my goodness. So Gosh, I don't even know how to start to answer that. We do have like a newly created role within our program. My colleague Denise Schimming, who's kind of our associate director of our survivorship program, and I know she spends a lot of time in what she does trying to get the word out there. I don't know if it expands, how much it expands beyond the James, which is a big organization, right, in and of itself. I mean, I know we do have a website and thing, but again, it's very James specific, that talks about our supportive care program. Gosh, geez, I don't even know how to answer that. It's like,
No,
I'm going to bet that Dr. Francis has some ideas on this.
yes.
As I know, working with Katie, I know your push-in model is similar to our opt-out model. When a patient selects a problem on the distress list, it routes automatically through our EHR to an appropriate subspecialist, whether that's a physical therapist, whether it's a dietitian. That individual then gets in touch with the patient. So there isn't this, we've got to think differently. A static referral, we make a referral, we make an appointment. We're using this more as a fluid consultative process for needs assessment. And I think, Dr. Francis, that might be what you all are doing with a push-in approach. Am I right?
Well, I mean, I think there's so many aspects to comment on. I think everyone is different. Everyone's coming at this with the different needs, different stamina, different resources, and I think that goes back to the word survivorship. Some people really like it and find it empowering. Some people find it to be a euphemism. I was talking with a patient's family member yesterday, and he said, Libby didn't like the word journey. She called it a carjacking, which I think, just this concept of like everyone sees things differently. And sometimes saying survivorship does not reflect a more analytical approach to the difficulties. So, and again, I think we have to balance the already hard work of recognizing that term survivorship, because I agree it is so hard to get people's attention. It is so hard to kind of get colleagues and patients and caregivers to know you're right there under their feet. And there's so much competition with different programs and different attention. And for many patients, when they get referred to survivorship, and again, this is a generalization, but a patient who is struggling either with symptoms or mental health issues, or at whatever point of survivorship that the person in front of them decides to refer them at, they are also being referred to behavioral medicine, palliative care, integrative oncology, and they don't even know what's happening. So we have to be more mindful of our words and choices. We have to be more mindful of the person in front of us. And we have to keep coming back, which is something that people have said, because this is dynamic. And we have to say, we talked to this person at this point. This is what was going on. Our plan is to re-engage in 3 months. And we have to use our documentation and our teams of nurse navigators and our warm handoff people and teams to have a point of view and a consistency around the language, the check-ins, the understanding that people are different, the understanding that we need recognition. So it is a tent and a town and a nation. It's a very complex landscape, but I think the attention to how different people are, and we can't overwork people. We have to sort of triage because as providers and administrators and organizers, I feel very acutely the energy I have to do what I need to do is limited, and I need to thoughtfully protect it and figure out when I'm working super hard to get things done and get recognition, and when I have to scale back and know, when I'm going to opt out. So I think all these things are super interesting to talk about, and I love hearing everyone's perspective.
It really does have to be so individualized, not just to like that patient, but that patient at that moment in time, I feel like, because it's great. Like we have all these resources and but sometimes it's just overwhelming to them to think about having one more appointment. Like they're just trying to like survive what they're doing right now. And so just kind of figuring what their priorities are at that moment in time too. And then, like you said, kind of circling back, we're going to reassess in a few months and kind of see where we are there, because the person or the needs you have now might not be the same as they are 3 months or 6 months or a year from now. That's okay, but we're here to kind of continue to help support you.
That's fantastic. Thank you. I'd like to give the next question to Dr. Erickson. And this one is, how do we create a primary care system that is educated about the unique needs of cancer survivors? And what are some of the best resources for busy primary care physicians to attain this information?
Yeah, thank you. I think this is a great question and something that we clearly need to do a better job with of, educating our primary care docs. We know that after treatment completion, the majority of the care is going to be by their PCs, right? And so we need to empower them. We have some low-hanging fruit that we can get the word out about, that we have survivorship guidelines, right, that are put forward by the American Cancer Society and ASCO for some of our more common cancer types like breast and prostate, head and neck, and colon cancer. The NCCN has guidelines that are more symptom focused, right? Like managing fatigue, managing sexual health, vaccines, whatever that might be. So we have those resources. And then for our pediatric survivors, right, we have the Children's Oncology Group guidelines that really spell out, you've had chest radiation, then this is what we need to be doing, X, Y, and Z. So I think some of it, before I got into this field as a primary care doc, I didn't know any of these resources, right? And so some of that is making them, just aware of that. Other options, there are some educational modules out there that are available online. For example, George Washington University has a course designed for primary care physicians about how to care for survivors. And then lastly, I think we need to kind of incorporate it more formally into our training, right? As part of, internal medicine, family medicine, pediatrics residencies, it's not really discussed. It's not a required piece of information. And so one thing that, we're working to do is incorporate some of that through just didactics with our trainees here at UC. But then we're also, this past year, we had our first sort of joint fellowship where we had 2 fellows doing palliative medicine that also received training in cancer survivorship, right? And that's something that we are working to kind of continue long-term, to have actually just a dedicated survivorship fellowship. So we need to have more formal training opportunities for our PCPs who have an interest. And I think there's a lot. I think, it's hard to find people who haven't been touched by cancer in some way. And so I think there are a lot of passionate folks out there who might be interested in getting involved and just aren't sure how they can tailor their practice.
Wonderful response. Thank you, Dr. Erickson. We do have a question in the chat, and I'll leave this to our panel of experts, but is there evidence that better survivorship care throughout treatment results in better outcomes in mortality and morbidity?
I can take a stab at that a little bit. I think the answer is yes. I think, oftentimes when I think about the things that I focus on, some of the comorbid conditions, that when patients are going through cancer, it's not uncommon that their blood pressure, it remains high for months and months, that their diabetes is potentially out of control. And we know that those can impact them in several ways. One, oftentimes, as I alluded to earlier, the risk of death is oftentimes higher, depending on the stage and the cancer type, from competing causes to the cancer. So I think that's important. Maintaining, managing these, because sometimes it can cause treatment interruption, right? If their blood pressure is too high or their sugars are too high, it can cause breaks in their treatment that may not be necessary had they been managed well. So yeah, I think we do have some data that keeping these other conditions under good control leads to better outcomes.
Yeah, there is absolutely evidence that individuals who participate in an structured exercise, have less chemotherapy dose reductions in lung cancer. A prehabilitation program, which is an all-encompassing psychosocial, physical, stress management intervention pre and up to and beyond the beginning of treatment, influences tolerability to therapies. And we all know dose reductions are bad, and our patients are not getting their optimal prescribed chemotherapy at that point. We also have good evidence that suggests individuals who lack a support network, have poorer outcomes. An emerging area that I think is critical for us to think about are the social determinants and how socioeconomic status, the stratification of individuals across socioeconomic strata, impacts their outcomes as well. So we know bringing along a support network beside someone improves outcomes. We know that these interventions can help to reduce, potentially prevent, and in some instances at least greatly mitigate some of the long-term and late effects. Some of the early work in this prospective model that Dr. Schmitz and I did together and highlighted was around early identification of a condition like lymphedema. So there's evidence that early identification of symptoms and early symptom management can prevent or greatly reduce long-term sequelae that are related to disability and long-term functional morbidity, and function not just being physical, but cognitive as well. So early intervention matters to physical function, to cognitive function, to disability. Where I think we need to extend that conversation is to really understand how it impacts disease endpoints. So tolerability to treatment has been looked at and studied to some small degree, but really, do we change disease-free progression because someone has better supportive care services? Do we improve overall survival for those individuals who participate? So I think bringing those outcomes does require larger studies, longer term studies. I'm hoping we'll see some of that with some of the work coming out of the ANICTO project through NCI, which is really looking at the exercise and nutrition capabilities to influence individuals during cancer treatments and cancer therapies. So there is a small body of evidence. It is growing, and I think the more robust our survivorship programs can become in being proactive, the more we will be able to robustly study these endpoints and the influence on these disease and treatment endpoints.
Very good. Thank you, Dr. Stout. For our next question, I'd like to go to Dr. Francis. And, kind of wrapping up around the conversation, a lot of patients express emotional discomfort with the transition from the many visits and active treatments to a more hands-off surveillance phase. How can we support patients through this transition?
Yeah, I mean, this is a challenge. And again, everyone's different, but a lot of people, especially I have more of a breast cancer practice, and the anxiety gets sort of pushed aside when they're in the active phase of treatment. They're just in a little bit of a battleground metaphor, and they're doing their thing. And then you get to the point where the active treatment is gone, or you're moving into a hormonal therapy, you're having less appointments. And it's a combination of more time, cumulative toxicity, just sort of the human mind, and people get very, very unsettled and anxious. And it's like a dance. It's really, really tricky. I find I see a lot of patients that have trouble with their hormone therapy and want to be off of it, or want a more natural approach and want to do less. And sometimes I find that those patients have more anxiety because they aren't doing things, or they're putting their anxiety more on the care team. It's very interesting. And there's so many different ways that things can be difficult. But I agree sort of with something Rashay said. Some of it is really just giving people space, giving people validation, agreeing with them, giving them examples of how other people are doing it, showing some vulnerability in your own self if you're comfortable with that. People really respond to that. It's really time and space that we can offer. And I do think that's an important part of the kind of surveillance medical survivorship piece, is a sense of comfort. We can't say you're going to be fine. We can't say this won't come back. So it is a balance of reality, but trying to really see that person in front of you and try to understand what they need from you in that moment. Some people really need to sort of flush things out. Some people really need a friend. I mean, and I think that's part of being an agile practitioner in the survivorship space. You're ready to try to read people. I mean, most of us have gone into this because that was something that we enjoyed. We want to be all sorts of different kinds of practitioners. So I think acknowledging, giving it time and space, trying to find some level of clarity, you know, these are your risks of recurrence. These are the things we can look for. These are the things we can't look for. I'm here. If you have concerns, please call. You know, sort of just really laying it out with sort of a competence and a clarity and a kindness and a calmness, a lot of C's here, but that's what I try to do.
I totally agree with you, Dr. Francis. I find it interesting how sometimes people come in and we have that emotional, like the, or not just emotional, but the distress screening tool that we utilize. And how some people will, by the end of the visit, just having given them the opportunity to kind of unload or vent, like, I'm not a mental health provider by training, but I feel like in that space sometimes, like, people feel like it is therapeutic, and even just that hour I have with them, by the end, they feel better than they did when they came in. And then also I feel like their anxieties are often related to having not really had that conversation. If we're going through like a care plan, like, what does come next? How often are you going to be seeing, doing, what should I be looking for? So just providing that education and that kind of knowledge base, and that giving them hopefully a little bit of sense of empowerment. These are the things that you can be doing that are in your control too, to help reduce your risk of recurrence, and educating on some of those good health practices and things like that. I feel like those things are helpful in that space too, and sometimes help reduce some of their uncertainty.
And just to be like a little more granular, because patients will say, am I getting blood work? Am I getting scans? And we rely a lot on the guidelines and the evidence that we have that by and large show a more minimal approach. And by and large show that labs, imaging, when done in a surveillance and symptom-free space, do not help people get diagnosed earlier with recurrence and do not improve our resources or the whole landscape. But that is a very uncomfortable thing to tell someone across the room. You know, so I try to really explain, here's what lab work does show or doesn't show. Here's why the guidelines were created. This is a more epidemiologic response, but you're a person. So let's talk about what your concerns are and what you think these tests could do or not do for you. So in the end, I try to stick with what is the evidence, but I always take a personalized approach. And if someone feels that they need a scan to move forward, we talk about that and we try to do what they need to move forward. So I think really getting into what is a blood test, what is a tumor marker, what is circulating DNA, what does a PET scan show, and what can it show that is problematic and what can it lead to, is a super helpful conversation for me to have with patients at this transition point.
Thank you all very much. We are getting near time. So one, I want to thank all of our participants for the excellent questions. Keep them coming in the chat. We will try to get to those. If we can't get to those today, we will try to get to those after the fact and get back to you. And please identify who you are so that we can get back to you. And thank you so much to our panelists. This has been a wonderful discussion. I hope this isn't our last question, but we are getting close to time. We'll start with Rashay, and I'd like to hear from the group. But changing gears a little bit, how can technology be leveraged to support patients in long-term care follow-up?
Yeah, so I think we really saw an explosion, and with COVID, right? How much more we've utilized technology. So at least like in my practice, being able to have these general supportive care visits and provision of treatment summaries, we give all our patients the option for a telehealth visit versus an in-person visit, whatever their preference is. And we get a lot of patients, you know, from all around the state, and during COVID, even sometimes the neighboring states had provisions in place where we could see them through telehealth. But you know, where in a situation, some people might not come for a survivorship visit, but they have the option of telehealth to stay in the convenience of their own home, allows us to reach them that way, to do, you know, the same sort of education and support that we would be able to give them in person. So I think that is one piece of it. And then even from an aspect of being able to virtually offer things like support programs. I mean, at James, we have our James Care for Life programs. So offering different classes in the realm of nutrition, exercise, mind, body, spirit. So we do have some of those in person, but I'd say probably about half of them are still offered through a virtual option. So it gives patients the opportunity to participate in those sort of support programs and through virtual. I mean, we have some different studies from so a couple we have right now in our survivorship clinic are able to offer like coaching virtually, like health coaching. So, I mean, I think that's very nice to be able to have that option to have participation in a survivorship study that's looking at optimizing health and wellness long term after cancer treatment through a virtual forum too. So. Those are just a few things there.
That's great. Any other thoughts on technology and support?
I think we have to be incredibly cautious about not driving greater divide and disparities by really vehemently pursuing pathways for telehealth. Dr. Young, you can appreciate here in West Virginia the lack of broadband connectivity. That's just one of the issues that is apparent in rural areas. You can't just turn on broadband and say, well, we'll pay for the patient's access. We don't have it. We work on satellites here, and we don't have that high-speed access. That makes video access incredibly challenging. Many of our patients, not just poor health literacy, but poor literacy in general, not just in West Virginia, but rural areas and really in the populace. It's I see a lot of flip phones in clinic. I talk about utilizing telehealth visits. Well, they have a contract plan for their mobile unit and the mobile device, and the number of bytes per minute or dollars they pay per byte limits them from downloading large files, from participating in a telehealth visit that takes up a lot of their minutes per month. So we've got to really be thinking differently. While I agree that telehealth and electronic connectivity are excellent opportunities, how do we operationalize that in ways that are meaningful and sensitive to our patients? Low touch, right? Text messaging, but even that, email, but even that, I've got patients who say, well, my son manages my email account, so if you're going to email me, it's actually going to go to him. So there are real challenges with the hand wave that we often give to some of these electronic means. That being said, I think we still need to pursue these digital technologies because there are great ways to incorporate these embedded into our electronic records so that if patients are home monitoring through a device, that information can be transmitted to the primary care provider, to the specialist, subspecialist for the information feedback loop to be complete. Again, using the technologies to not just characterize the problem, but actively engage someone who can help to manage that situation. So I think that the future, hopefully the opportunities will continue to expand in the digital environment, but I think we just have to be sensitive about that and realistic as we introduce it to patients. When they look at us sideways, hand them an iPad, I don't read so well, or I've never really used one of these before. So being sensitive to those types of things is important as well.
Thank you, and I agree. There are limitations with access, and it gets back to social determinants and having the support networks, whether it be the friends, the family, the in-person support systems, the healthcare providers being the support system. But there are areas where we still lack the technology and a lot of great work to be done. So we are about down to our last moment. So I will turn this back over again, thank you to our panelists. This has been a wonderful discussion for the participants. This panel of experts at the top of their field and the experience that Julie has added to the panel today. Thank you all so much for being part of this and allowing me to be part of this as well. So I will hand this back over to Liz for final words. Thank you.
Thank you, Dr. Young and panel members, for a great discussion. Now, before we wrap up for today, we wanted to share an American Cancer Society resource that can help support cancer survivors and caregivers. Yeah, we're not getting any sound on that, so I apologize. Yeah, sorry for the technical difficulties. We can probably post that in the slides at the end of today's session. But you can also check out our CARES app at the QR code or the link in the chat. I'm just waiting for that slide to show you. Still having some technical difficulties. Okay, there it is. There's the QR code, so you can check out the American Cancer Society CARES app. All right, now for our final poll question, after hearing from our excellent presenters, how confident are you with your knowledge of issues in cancer survivorship? How confident are you with your knowledge of issues in cancer survivorship? Number 1, not confident at all. Number 2, slightly confident. And 3, somewhat confident. Okay, just take a few minutes for everyone to answer this. Our last poll question. All right, now please join us for the next virtual forum on November 21st. We will be discussing navigating issues in palliative care. Please note that this is a new date for the webinar. Due to scheduling conflicts, we had to move the date back a week. If you have already registered, you should have received an email, but be sure that the change is reflected on your calendar. The CME certificate will be sent out 2 weeks. Once you've completed the post-event survey, the survey will pop up at the close of today's session, and you will also receive a post-event email with a recording of the session and the survey link in case you've missed it this morning. And we are also pleased to share that this program and all previous programs in the series will be available on YouTube. Right there, there is the link. CMEs are only available for the live event, but please share what you've heard here today with your colleagues, or check out some of the sessions that you may have missed this morning. So I'd like to thank you again for joining us today, and thank you for your commitment to fight for a world without cancer. Have a great day.